Good morning, everyone. I am Rachel Lieberman. I am a director here at the Celiac Disease Foundation. I want to welcome you on behalf of myself and my co-directors, Dr. Bana Jabri, as well as Dr. Ritu Verma, who is here with us and will be leading the program today. I want to thank our sponsors of our program today, Celiac Disease Foundation, as well as Karen and Eric Simon. We want to thank our speakers for their generous time and knowledge. We're really excited for a fantastic morning of programs. I want to make a few housekeeping announcements. Throughout today's session, we encourage you, as someone already has, to use that Q&A function at the bottom of your screen to ask speakers questions during their presentations. We will be addressing these questions during the Q&A portion of the session. Other comments can be placed within the chat box. Videos of today's session will be posted within 3 to 5 days after the conference on the virtual conference website that you are on today, gathering the program. Instructions to claim your credit were sent this morning. We will send them again after the conference. For CME information, you can scroll down to the CME information section on the virtual conference website. If you would like to update your registration type so that you are able to claim credit, please contact our CME office at cme@bsd.uchicago.edu. I will put that in the chat and they will proceed with your payment. You can also find the tech support email at the bottom of our website in the event that you need any technical help this morning. And after this session, please return to the main website and scroll down to the next session and click the yellow button that reads, "Click here to join session 2." You'll be asked to type in your name, email, and other items for attendance purposes and then directed to the session. So we want to welcome you again. I am thrilled to have you at the Neurological and Psychological Implications in Celiac Disease. I would love to introduce our medical director of the our Celiac Center, Dr. Ritu Verma, who is also Chief of Gastroenterology here at University of Chicago Comer Children's Hospital. She will be leading us this morning and throughout the program. Thank you, Dr. Verma.
Thanks, Rachel. Good morning. Lovely to see a lot of people on the Zoom. Would have been even better if we could have all met in person, especially today where Chicago is really coming out with a beautiful, beautiful sunny day. So hopefully wherever you are, it's not too bad. Or maybe if the weather is bad, then it's easy to sit on Zoom. Regardless, really excited. We have a wonderful lineup of speakers today, and hopefully by the end of this session and the next session, we'll have learned a little bit more about where we are in celiac disease and also our neurological and psychological manifestations. So just as a background, all of us know that celiac disease is an autoimmune disease and can affect any organ in our body. And we know that initially the diagnosis is made on a blood test where you look at different antibodies. And once someone looks at the antibodies and they're elevated, we move on to an endoscopy majority of the times and look at the biopsies of the small bowel and hence make a diagnosis of celiac disease. So sounds pretty easy, right? But not always this simple and not always this easy. And part of the reason is for anyone to even think that you need to have a blood test done, you have to think about listening to a patient and saying, are these symptoms thought of in celiac disease? So all the time people will say, if you have abdominal pain, diarrhea, weight loss, do a celiac antibody panel and you make a diagnosis. But not everyone has those symptoms. There are people who have just constipation, they actually have weight gain. So we know that there are no just absolute symptoms that are associated with celiac disease. There are people that have no symptoms and they're picked up on a family screen. And again, my public service spot here, don't forget, family screening is really important in celiac disease. It's a genetic condition, and you can have family members who will end up with the disease without really having any symptoms. So really important that the screening be done. There are people and children with type 1 diabetes who do not have any classic symptoms and have celiac disease. So therefore, as a clinician, you need to think about doing a blood test. Other symptoms that we sometimes forget about are more looking at the blood tests. Anemia, where you don't have a specific reason for the anemia, low bone density, thyroid abnormalities, liver enzymes. So a myriad of signs and symptoms can be associated with celiac disease, and hence blood tests needs to be done and go down the diagnosis of celiac disease. And I think in the world of celiac disease, we've been successful in working through with our colleagues in other subspecialties and making them aware and making everyone aware that those are associated symptoms with celiac disease, and we do need to do the blood test. What has happened, however, is that the psychological and neurological symptoms are often overlooked. And part of the reason they are overlooked is because, again, it's not where those were the first signs and symptoms that were associated with celiac disease. So and I'll bring myself into the clinician world, is we tend sometimes to overlook those symptoms as a reason for celiac disease. So perhaps we may not do the testing because our knowledge base may not be there, and therefore we are not doing the testing. The other sort of tough spot that we have with psychological and neurological manifestations is that we don't have a good test. And if we don't have a good test, it's hard for us to then go down that path of diagnosis. So we are hoping that today, and we did a similar event last November, is we would have more of a discussion and more of a learning for our clinicians, for our researchers, and for our families, that how do we go on this journey of learning, exploring, and figuring out how to diagnose and treat children and adults with psychological conditions and neurological manifestations of celiac disease. So that was really the purpose of us to put the CME symposium together today. And I do believe, looking at the talks, that we will be successful in achieving that purpose. So it's a partnership, right? So it's a partnership between clinicians, researchers, and families. All of us need to work together so that we can move forward and learn more about celiac disease. In order to kick off for today, it's my pleasure to introduce Dr. Hilary Jericho. She is an assistant professor here at the University of Chicago, a member of my team in the section of pediatric gastroenterologists. And she has a very, very special interest in celiac disease, but she's an accomplished gastroenterologist who also takes care of children with inflammatory bowel disease, irritable bowel syndrome, abdominal pain, and also liver disease. So a very, very accomplished pediatric gastroenterologist in our section. And one other, I would say, exciting thing about Dr. Jericho is that she doesn't just stop at the conventional stuff. So one of the things that she's also doing is leading the program with a video capsule endoscopy and seeing how can you use a video capsule endoscopy for the diagnosis and prognosis and things with celiac disease. And that'll be a topic of another day, but just for you to know that she is the expert for that. And today she'll be discussing the neurological manifestations of celiac disease. So Dr. Jericho, the floor is yours.
Thank you very much, Dr. Verma, for that incredible introduction. And I must say I have to put out a plug for Dr. Verma as well, as she is honestly one of the best bosses and mentors anyone could actually ever ask for. So it's been a pleasure working with her as well. So I will pull up my slides. Oops, I just need to open this up a little bit to get to that screen share. All right. So thank you for having me today. It's an honor to be here. I will be discussing the neurological manifestations of celiac disease and breaking it down into the four kind of most common neurological manifestations that we see. And then each of these components, actually, there'll be future talks later in the day today that will go into these, I believe, in a little bit more detail, but I'm going to give a nice overview of everything to start out with. This is my disclosure slide. I have no relevant financial relationships, and I won't be discussing anything that's off-label or investigational. All right, so we'll start with the background. So neurologic disease, it's thought to affect roughly 6 to 10% of patients with celiac disease. The underlying etiology is still not 100% crystal clear, but it's thought to potentially be secondary to either a vitamin deficiency or an autoimmune aspect. Headache is one of the more common neurological manifestations that we see specifically in children and in celiac disease as a whole. And then in adults, the most common neurological manifestation that we see is peripheral neuropathy. Seizures account for far less cases, and then gluten ataxia is seen least frequently. This slide, I've always liked this. It kind of gives you a rough estimate of when certain both GI and extraintestinal manifestations tend to arise within the lifespan of people who ultimately develop celiac disease. And while it's, doesn't account for every person and not everybody reads the textbook, this is the general trend. And what studies have shown is that oftentimes the gastrointestinal manifestations affect children much earlier in life, or affect individuals much earlier in life, while many of the extraintestinal manifestations are seen in the later years of childhood, teens up until the 20s, and then in adults. And ultimately, it's thought this is probably because the mechanism that causes the gastrointestinal manifestations is a much more simplistic mechanism than that which causes the extraintestinal manifestations, leading to onset later in life than those traditional gastrointestinal symptoms that we see. All right, so quickly we'll run through the mechanism of action. So as I said, it's thought that potentially the main causes that account for these neurological manifestations are either nutritional deficiencies or potentially an immune mechanism. The nutritional deficiencies occur secondary to the enteropathy and the damage to the gut caused by celiac disease, ultimately leading to malabsorption of these specific nutrients. It's thought that it may play a part in the development of the neurological deficit, but probably doesn't account for the entire reason behind the onset of that neurological manifestation. The suspected nutrients that may be causing these neurological sequelae include calcium, folic acid, pyridoxine, vitamin B12, vitamin E, biopterin, and then carnitine. And the reason it's thought that it probably doesn't account for the full explanation of these neurological manifestations is that oftentimes people will have one of these neurological manifestations of celiac disease when they have no vitamin deficiencies at all. Oftentimes when you try to replace the vitamins that are deficient, you don't see a dramatic improvement in the symptoms that the patients had. And there's patients with celiac disease who have profound deficiencies and they don't have neurological manifestations. All reasons to support that while those vitamin deficiencies, again, may play a part, they're probably not the complete picture. Moving on to the immune dysregulation. So it is thought that it's likely an antibody-mediated process. And the reason behind that is findings from many studies that have shown anti-glioside antibodies in up to 65% of adults with celiac disease and polyneuropathies. The presence of tissue transglutaminase antibodies, specifically the tissue transglutaminase IgA6 antibody, found to be surrounding the blood vessels in the brain of celiac patients who have epilepsy and gluten ataxia. And then the anti-gliadin antibody, this is not the present day antibody that we often send in patients with celiac disease, which is the deamidated gliadin peptide, but the older antibody that was sent many years ago called an anti-gliadin antibody, which has been found against the cerebellum Purkinje cells in gluten ataxia. So I want to start out, it's always a little more fun hearing lectures when there's something more personal and talking about individual patients. I'm going to start out with two case presentations of patients I have seen, and then I'll wrap up at the end with kind of their longer term outcomes after treatment. So the first patient was a 7-year-old male who came to me with what they said was just migraines. You may say, why did a child with isolated migraines get screened in the first place? So he did have an older sibling who was diagnosed with celiac disease, and typical protocol for most pediatric and adult gastroenterologists is that when a patient's diagnosed with celiac disease, because they're first-degree relatives who will include their siblings, their parents, and ultimately children of that individual, they share more genes and genetic material with that person who's diagnosed with celiac disease than anybody else. So they have a much higher likelihood of developing celiac disease. It's thought potentially even up to a 15% chance of developing celiac disease. So most gastroenterologists will screen these first-degree relatives regardless of symptoms. So that was this patient. He got screened because of his sibling, and at that time he reported no gastrointestinal symptoms in what we would ordinarily think of gastrointestinal symptoms being things like diarrhea, vomiting, weight loss, abdominal pain. He did report that he had recurrent oral sores that would come and go quite frequently. And then the big issue he struggled with was migraines. He had excellent growth. And then his screening labs, a TTG IgA had been sent, elevated to 167. The scale normal was less than 20, and then a normal total IgA level. On his scope, he had a normal esophagus, a normal stomach, but in both the duodenal bulb and the second portion of the duodenum, he was found to have moderate villus blunting, an increase in the intraepithelial lymphocytes, and crypt elongation, which are pathognomonic for the diagnosis of celiac disease. He was started on a strict gluten-free diet after these findings. My second patient, who is a very, very fascinating patient, was actually a 5-year-old male who came to me with symptoms suggestive of a peripheral neuropathy. He had had a very severe viral illness, and unfortunately, after the initial symptoms cleared up, he continued to have these recurrent bouts of non-bilious, non-bloody emesis, diarrhea, bloating, and then this repeated kind of tingling of his hands and feet. Celiac testing was sent with a mild elevation of the TTG to 44, and normal less than 20. He did have a normal deamidated gliadin peptide, and then a normal total IgA level. On his scope, again, he had a normal esophagus and stomach. He had a normal duodenal bulb, but in the second portion of the duodenum, he was found to have moderate villus blunting and an increase in the intraepithelial lymphocytes, again, consistent with the diagnosis of celiac disease, and also was started on a strict gluten-free diet. So in the next handful of slides, I'm going to go through the more common neurological manifestations of celiac disease that we see, going from the ones that we see more frequently to those that we see less frequently. These slides will cover the topics of headache, peripheral neuropathy, seizures, and gluten ataxia. So headache, overall, while a lot of patients with celiac disease are affected by headaches, it doesn't seem the prevalence is that much greater than that of the general population. It does tend to affect females more than males, and oftentimes if these individuals have higher rates of anxiety and depression, we do see it more frequently in that population. The headaches that we see more often include migraines and tension headaches, and many of those patients, similar to the patient I saw, have silent celiac disease or wind up having a very late onset of celiac disease symptoms. The speculated etiologies include vitamin deficiencies, potentially low levels of serotonin, and then a gluten-induced impaired immune response, which can lead to an imbalance of the pro-inflammatory cytokines. This leads to an altered vascular tone and subsequently the onset of that headache. The treatment for these individuals is the gluten-free diet, and it is found that they have an overall very excellent symptom response to this. The next category that we'll cover is peripheral neuropathy. It's found in roughly up to 49% of adult celiac patients, far less frequently in children. The neuropathy often antedates the celiac disease diagnosis, which often is silent. Only 25% of patients are found to have an enteropathy on the biopsy, but the recommendation is to start the strict gluten-free diet even in the absence of the enteropathy if there's other findings, again, to support the diagnosis of celiac disease, such as those elevated celiac serologies. It can include both large and small fiber neuropathies, which ultimately cause symptoms of having painful paresthesias of the limbs, a variable sensory loss, and then in up to 25% of patients, they may have a gait instability as well. The speculated etiology for this is an immune dysregulation. And as I was saying before, in studies, they have found the presence of those anti-tissue transglutaminase IgA, specifically 6 antibodies in both the large and small nerve fibers. With regards to treatment, again, it is the gluten-free diet, but there are mixed findings on the rates of symptom response. Unfortunately, up to 23% of patients will have continued symptoms despite a strict gluten-free diet. Adjuvant IVIG can be very helpful to treat the neuropathic pain when the patients are found specifically to have the small fiber neuropathy. The next topic that we'll cover is epilepsy. This is seen more frequently in children than adults, and most often is found in the occipital lobe, which causes partial seizures with or without generalization. In some cases, though less often, you can have hippocampal sclerosis and temporal lobe epilepsy. And very specifically, and actually our own Dr. Guandolini many years ago in the 90s was one of the first people to report this in celiac patients. Up to 42 to 77% of patients with epilepsy and those cerebral calcifications specifically will have celiac disease. It's thought that the cerebral calcifications may be associated with a folate deficiency specifically, as other disease entities that also cause folate deficiency can present with similar symptoms. There's a very good response to the initiation of the gluten-free diet. And over here in these pictures, if you can see my mouse, these are taken from a study from Gabi et al. The title of the article was called Celiac Disease, Epilepsy, and Cerebral Calcifications back in 1990 and 92, which was, again, one of the first articles addressing this specific condition called CEC. In these pictures, what they're showing is the location of the cerebral calcifications in 29 patients that they had with CEC. And then specifically, let me move us out of the screen here. This slide over here shows the bilateral occipital cortical subcortical calcifications in this condition, which you can see right here in the occipital lobe. The speculated etiologies for this condition are either a gluten-mediated toxicity, immune-induced cortical damage, the presence of the cerebral calcifications on their own, and micronutrient deficiencies. The treatments are anti-epileptics, plus or minus the initiation of a gluten-free diet when the epilepsy is refractory to the medication alone. There's really good rates of improvement in these patients with improved EEGs in up to 48% of patients 6 months after starting that gluten-free diet. Last but not least, I'll touch upon cerebral gluten ataxia. This tends to occur much later in life. It is exceptionally rare. I've never seen a patient, and there's very few case reports of this occurring in children. More often, it occurs in adults, typically in their 50s. It affects males more than females. It'll cause difficulty with balance, gait instability, which is the ataxia, limb trembling, and nystagmus. Many of these patients lack GI symptoms at all or vitamin deficiencies, though when they do get a scope, they are found to have that classic celiac enteropathy on their biopsies. When imaging is done of these patients, which the most frequent imaging modality is an MRI, the finding is atrophy of the cerebellum, which you can see here. This is a normal cerebellum, and this is the atrophic cerebellum. And last but not least, there has to be an absence of any other alternative etiology. The speculated etiology for this condition is immune dysregulation. This has been supported by the findings of anti-gliadin antibodies against the cerebellar Purkinje cells. Unfortunately, once those cells are lost, that is not reversible. There's also been the findings of that tissue transglutaminase 6 antibody deposited in the cerebellar blood vessels, suggesting that there is a blood-brain barrier dysfunction. The treatment is, again, the initiation of a gluten-free diet. When it is started early, there are much better rates of response, and typically better rates of response in children versus adults, in which scenario the disease process has been probably going on longer, leading to more damage that is much harder to be reversed at that point. And if patients don't have an adequate response on the gluten-free diet alone, an adjunct therapy, again, is intravenous immunoglobulins or IVIG. I loved this graph that I wanted to include in here. It sums up a lot of what I just previously went through on rates of response in different neurological manifestations of celiac disease. This was from a paper by Ziz et al. Entitled The Treatment of Neurological Manifestations of Gluten Sensitivity in Celiac Disease in 2019. On the left side of the chart, you'll see the gluten-related disorder. There were more in their chart, but I specifically picked the 4 that I discussed today, which are the more common manifestations that we see, including headache, peripheral neuropathy, epilepsy, and ataxia. In the second column, you'll see the type that they specifically address, including, again, most of the topics that I covered, including that epilepsy, cerebral calcification syndrome. In the third column, that's the aspect of the disease entity that they looked at. And similar to my slide leading up to this, the response to the gluten-free diet in the last column on the right. And as you can see, similar to what I just presented, overall, there are very good rates of response in symptom improvement to the gluten-free diet. This is my last slide before I come back to those 2 cases I started with. This is specifically from a study that Dr. Guandolini and I had performed a number of years ago, looking at the extraintestinal manifestations of celiac disease in both children and actually adults with celiac disease. On the left chart are children, and on the right chart are the adults. And I narrowed down this graph. Originally, it had all of the extraintestinal manifestations, but I narrowed it down specifically to the neurological manifestations that we were able to uncover in this retrospective chart review that we did. On the left-hand side with the children, this was looking at seizure and headache improvement after initiation of the gluten-free diet. And in adults, this was looking at rates of peripheral neuropathy and headaches. Overall, again, supportive of the slides I reviewed leading up till now, there are very good rates of improvement in these neurological manifestations of celiac disease on gluten-free diets. One of the main points that we found in the study was that these rates of improvement tend to be more complete, occur more quickly in children as compared to adults, as you can see illustrated by this graph. In children with seizures, by 13 to 24 months, all of our children with seizures who had gone on a gluten-free diet had resolution of the symptoms. The headaches, while dramatic improvements, they weren't 100% resolved by that 24-month mark, but significantly improved. And then in adults too, the rates of neuropathy and headaches had greatly improved by 24 months on the gluten-free diet. Again, not as quickly and not as completely as with children, but still very good resolution nonetheless. So coming back to our 2 patients, first our 7-year-old male with the migraines. By 12 months on the gluten-free diet, he had complete normalization of his celiac serologies and complete resolution of his migraines and that oral stomatitis that he had. Interestingly enough, when he would have accidental gluten consumption, he would develop migraines within 24 hours of that, consistent with his pre-diagnosis symptoms that he had. But as you can see here, and as illustrated by the slides leading up to this, in children, there's exceptional rates of resolution of these neurological manifestations on a gluten-free diet. Last but not least is our 5-year-old patient with the peripheral neuropathy. Similarly, 12 months after his diagnosis, he had complete resolution of his celiac serology abnormalities, as well as complete resolution of both his GI symptoms and the symptoms suggestive of a peripheral neuropathy. When he would get exposures, his symptoms would include pretty significant vomiting and a recurrence of that numbness and tingling of his hands and feet, which was always very fascinating to me. I mean, they knew when he would get exposed, which was very interesting. So that is the end of my presentation. Thank you for having me today. It's been a pleasure to be here.
Thank you very much, Dr. Jericho. Excellent, excellent presentation as always. So thank you. Just for everyone to know that, yes, we will have the slides up a few days from now, and Rachel will give us more details towards the end of this seminar. We also will have Dr. Nordley, one of our neurologists, who will talk a little bit more, quite a bit more about epilepsy. So stay tuned, you'll hear more about that. And the questions that are coming in the Q&A, we will be addressing them in a Q&A session right after the first session speakers. Moving along, Dr. Sarah Keedy is our next speaker. She is an associate professor of psychiatry and behavioral neuroscience here at the University of Chicago. And it's indeed my pleasure to introduce her, but also to let you know that her research interests are psychosis and neuroimaging. And her lab really focuses on this. She has written widely on this topic and truly is an expert in this field. And today she'll be taking a real deeper look into the brain fog study from a neuropsychological perspective. So looking forward to the talk, and thank you so much, Dr. Keedy. The floor is yours.
Thank you, Dr. Verma. It's fun to be here, to be a little bit out of my comfort zone, participating today in this conversation about celiac disease. I've been kind of newer to the field, joining in to help out with this study of brain fog associated with celiac disease that the Celiac Disease Center folks have been working on. So I'm just going to share my screen here and get the talk going. And I think we have to acknowledge what an amazing thing. We're running a bit ahead of schedule. How about that? We'll see if I can keep it going. So I'm going to share this, and then I'm going to put my slides up. Okay. Somebody holler at me if it seems like you don't see the title slide, but I'm presuming everybody sees the title slide okay.
Yes, we do. Thank you.
Oh, good. Okay, wonderful. Yeah. So I am here to talk about. Really, I'm part of a team that's going to be studying brain fog associated with celiac disease. It's a study that's kind of just getting underway here, and I joined that effort kind of in the last several months. And unfortunately, you know, of the team, I'm really the only one who could show up today, who is available today to be part of this conversation. In some ways, I regret that for the sake of the audience, because I'm not sure I'm the best expert in a number of things really specific to celiac disease. I'm learning as I go in some ways, but what I do is study the brain, and I study the brain in terms of brain behavior relationships, cognition and emotion function, and I do focus on psychotic disorders, but I regularly collaborate with colleagues who are looking at a number of disorders in psychiatry and in other fields of medicine. And so it's certainly within my wheelhouse to be a collaborator in this way, and I'm happy to share my expertise in this space. And I have nothing to disclose, I have no relationships, and I'm not going to talk about financial relationships of interest, and no off-label use will be discussed. So let's just kind of get on the same page real quick about this concept, brain fog. Brain fog is a term that people use to describe, I think, an experience of themselves that is, they're feeling off in some way in kind of two domains, thinking abilities, cognition, how, really like thinking skills, and I'll talk more about that in a bit. And then also they might be describing problems that are with how they're feeling emotionally, feeling anxious, depressed, or not themselves in some kind of way. So maybe their personality feels kind of altered. And so people have all kinds of variations on these two themes when they feel like they're experiencing brain fog. But ultimately, brain fog is not a medical diagnosis, it's not a medical term, but funnily enough, it is kind of infiltrating the medical literature. This is a graph that displays how often this term brain fog is popping up in PubMed, which is the database of the medical literature that many of us use to search, and it's getting more and more popular as we go. And I think one of the things we really have to acknowledge around this is that there is brain fog associated with COVID-19. I created this slide just a few days ago, and I'm not sure if you guys can see how recent this is, but here's all these news stories commenting on brain fog. It's coming out every few days. There's some news story commenting on it. So brain fog is on a lot of people's minds. And certainly when we think of COVID-19, we think of the potential interactions of the immune system cytokine storms and things like that, probably and maybe having something to do with what's going on with the brain fog experience of COVID-19. So any investigations in those spaces might be quite helpful for a variety of conditions people are experiencing. So let me just kind of take a deeper dive into cognitive complaints. And as a neuropsychologist myself, when I hear people begin to describe what they're really experiencing, how I sort of categorize it, different kind of cognitive domains. And so people might complain that they're having trouble getting new information into their brain. They're having trouble with learning, or they might be having trouble getting information back out that they're pretty sure is already in there. They're having trouble with remembering information, right? Or a common complaint could be they have trouble manipulating information online, can't do a simple math problem in their head, or maybe have trouble speaking clearly, speaking articulately, maybe having trouble getting a word that they know they have, but they just can't spit it out. That tip of the tongue phenomenon might become more frequent. It could be basic trouble with sustaining attention and concentration for a period of time, paying attention to a book, paying attention to a speaker in a symposium over the course of a morning. Sometimes people may find that their speed of thinking, their sharpness seems dull, they're not quick, their processing speed is degraded. There could be a sense of alertness being altered, they're not as alert, they're feeling sluggish, they're feeling fatigued. Sometimes just having flat moments of disorientation, just kind of not sure, what day it is, where are they they're quite transient, typically in a brain fog complaint scenario, complaints can include a host of things that we kind of lump together as executive functions. And these are kind of higher order cognitive functions like difficulty planning effectively, difficulty inhibiting an impulse, difficulty making decisions. Those are all kinds of things we consider as executive functions. So any one of these things could go along with brain fog related complaints. And that's the cognitive piece. And then the emotional piece, a whole lot of complaints go there, but quite commonly, I think we just see them in the general categories of depression type of complaints and anxiety type complaints. And I'm happy to just also plug for you guys this movie Inside Out. If you haven't seen it, that came out a few years ago. I think it beautifully illustrates a lot of things about our emotional functioning. It just makes a fun slide too. But no doubt with brain fog complaints, people will maybe throw out a few symptoms that might not meet the full criteria for depression or anxiety, but complaints of feeling sad, complaints of not being able to enjoy anything, that's anhedonia, feeling worthless, feeling highly guilty, even suicidal ideation, which I didn't put on the slide, but people can bring that up at a passive feeling really bad for just a few moments, but you can end up going there with your thinking. And then for anxiety complaints, it's probably worth pointing out that anxiety complaints really break down into two kinds. There's cognitive complaints, like the thought-based experience of just really worrying or feeling quite concerned and fearful about something. And then there's physical complaints that go with anxiety, right? The sympathetic nervous system getting kicked on, where you're experiencing increased heart rate, sweating, and I don't have it on the slide, but GI complaints, of course, right? So that gets very complicated very quickly with GI complaints and anxiety. But then also folks might just talk about things where I don't feel like I'm handling things the way I normally would. I feel more irritable. I can't, I can't tolerate things that are very frustrating as easily, and on and on and on. So it's just a wide range of things that people might complain about when they're describing a brain fog experience. And this is the case for celiac disease, near as I can tell so far in my kind of diving in to try to understand something about it. What do we know so far? How do we begin to think about brain fog and celiac disease? Well, beginning with, I don't think this audience needs to know this, but celiac disease is a multi-system affecting disease, including the brain and the neural system. And we know there's kind of like two categories of ways that we see those manifestations. And I think the previous speaker really covered number one, the big neurological manifestations, the grossly observable neurological manifestations. But then there's the second group. This is maybe more silent kinds of CNS impacts, which, for example, you might be able to see white matter changes on MRIs, and there's really no clinical correlations. There's no complaints to go along with it. So that would be like a silent effect. But then maybe these transient effects, brain fog coming and going, might also kind of count as another type of silent impact on the central nervous system. And to my understanding, and certainly other experts could jump in, I don't know that we have a good sense of the prevalence of brain fog complaints in celiac disease, but just kind of reading and interacting with experts, I get the impression that an awful lot of folks with celiac disease will complain of a version of brain fog upon accidental gluten exposure once they get on those gluten-free diets. So it's pretty darn common, I guess, is the bottom line. Here's a pretty slide with a lovely cartoon about all of the possible, some of the possible mechanisms for how we can get from celiac disease to brain fog, starting in the gut. I just wanted to mention a bit, but basically what we're thinking about is the way the immune system is activated, and the immune system impacts the central nervous system. But here we are in the gut to see how does the immune system get activated at all. And I'll just briefly mention that one key thing to be thinking about is the microbiome. And certainly there's been documented imbalance in the microbiota in the gut in celiac disease, and a whole host of problems cascade from there, including a highly activated immune system. And you can see in the slide that there's a whole lot of molecules implicated and could be causing trouble, leaky gut syndrome and so on. I'm not going to go into the details of that. I'm not able to do so intelligently, but just to kind of throw out there, it's a complex possible set of mechanisms at play that are affecting the immune system being activated, and that we know the immune system has a lot of potential neurocognitive effects. And my next set of slides just kind of reminding us what we know about immune system effects on neurocognition. And we have some great examples of conditions that teach us what that looks like. Example number one being cancer patients who get high dose IL-2 therapy. Most of them will end up complaining of cognitive and emotional alterations, and a wide variety of them at that. You can see the long list of cognitive and affective kinds of complaints, and it's a pretty broad range of them. So there's quite diverse impacts from this kind of treatment. And then the other example is hepatitis C patients who are given interferon alpha treatment, and you end up seeing after that treatment a high incidence of depression that seems quite associated with the treatment itself. So these cytokine alterations impacting neurocognition seems quite clearly associated in these two scenarios. And then, another group of disorders, the autoimmune disorders, all clearly seem to have neurocognitive effects, celiac disease being one of them, but there's others that we can kind of just look at and know that, there is some connection there. The sepsis being a good one to think about, sepsis where the body is just, the immune system is kind of in overdrive big time, and there's delirium associated with that condition. Folks who've had septic shock later on MRI, we see white matter abnormalities quite commonly, and gray matter damage can be documented with evidence of neuroinflammation right in the gray matter of the brain. There's animal models that kind of help us try and understand what's going on, kind of getting at some mechanisms of inducing sepsis, and within 24 hours, we see how the blood-brain barrier, this is really the key place where we likely want to understand how is the immune system alteration affecting the central nervous system. It's probably how the blood-brain barrier is getting affected, and I'll go into that a little bit. But there's a variety of mechanisms, including possibly affecting the neurons themselves, neural degeneration, neuron spine density reducing. So, actual neurons in a key place like the hippocampus having fewer connections, certainly we can see how that might impact functioning. It's just another sort of thought experiment for like, how does this happen? This is one possible way to think about how neurocognitive changes happen. Post-surgical cognitive decline is another space to really think about how the immune system affects cognition. And this is a really huge problem, especially for older adults who experience cognitive decline after surgeries. And animal models have taught us some things. And just to pick one example, there's an interesting study about blocking TNF alpha, blocking the cytokine cascade associated with that surgery, and then just assessing how we have no microgliosis in the hippocampus. This is one of the mechanisms of the blood-brain barrier integrity. If you can kind of stop that process, you might be able to stop the microgliosis. And then also the observation was that the mice didn't have the quote unquote cognitive effects as well when they were given the TNF alpha blocker. So, we know that when we look directly at the immune system in these ways, and we can manipulate the neurocognitive effects, we really think we're onto something in understanding the relationships of the immune system to central nervous system function. I'll just throw out a few more examples. Lupus, another autoimmune disorder with a lot of pretty obvious neurocognitive symptoms. And again, it just comes down, there's a lot in this slide. I think these slides are going to be available for people to grab if you want to have it and kind of think it through. But it comes down to the bottom bullet point, that blood-brain barrier, getting increased permeability, and a lot of pro-inflammatory cytokines getting in there and wreaking havoc. The last condition, autoimmune condition I'll mention, is multiple sclerosis. Just to remind everybody of this one. definitely a disorder of the immune system. And really the key deficits, the key impacts to the body are there's inflammation, then there's demyelination of the white matter, and there's neurodegeneration with the gray matters being affected as well, and diverse neuropsychiatric complaints with any of the varieties of multiple sclerosis. And then here at the very bottom of my slide, I just wanted to throw out there and remind people that, while we're looking at all these systemic mechanisms to think about it, we also have to keep in mind that there's genetic components typically to all of these disorders that put people at higher risk for these kinds of neurological impacts. So that's a very complicated picture. But let's just zoom in real quick at the blood-brain barrier and just kind of look at in a specific way what can be happening. Again, not my special area to be great at describing, but I'll do what I can. So on the left side, we have healthy brain tissue zoomed in. We see neurons, we see the blood vessel, and we see white matter cells that support that system. And on the left, we see a system that is quite affected by an activated immune system. And some of the key things that are happening here is we see the oligodendrocytes, the white matter cells, whose job it is to really support the axons of the neurons that connect. They want to connect to each other, these neurons, to talk to each other. And the oligodendrocytes have the job of putting wrapping around and helping that connection run smoothly. But when we have an inflamed situation, we have autoimmune systems going a little bit berserk, that system starts to degrade. And so the communication between neurons also degrades, the neurons themselves degrade. We also have things like microgliosis going on, where the job of the microglia is to keep things clean and keep things running smoothly. And when they're not doing their job, you get further cascade actually of immune function, of immune system activation. We also have astrogliosis, the astrocytes, other white matter cells, whose job it really is to help with the interface with the blood cells, with the capillaries, to do the exchange of things that's supposed to happen and keep exchange that's not supposed to happen out, but the tight junctions are getting disrupted. And so that's another kind of source for how the blood-brain barrier disruptions are occurring. So it's very complicated. There's a lot of potential mechanisms at play here. And then I just want to throw out one final example, which is to say that in my field in psychiatry, we are interested in a variety of ways that the immune system may be creating the psychiatric disorders themselves, might be impacting the manifestation of things. And this is just one example I grabbed, a very recent review article of somebody putting together a series of immune mechanisms that might be at play for bipolar disorder. So again, slide is kind of similar to the last one, where we have a healthy brain situation and we're looking at proteins at the tight junction themselves. And on the right, we see, the hypothesized abnormalities in bipolar disorder, including, problems with Claudin-5 protein really being one of the proteins that there's a bunch of things being focused on. I'm just picking that one, but we can see all the extra immune molecules floating around, creating the situation where the tight junctions are disrupted, the blood-brain barrier is disrupted, and somehow or other it is contributing to the manifestation of bipolar disorder, which is a significant mood disorder. So everybody's thinking about immune system function and how that impacts the central nervous system. And then somebody like me gets roped into this conversation, and what am I doing with this? Now we're going to zoom way out. This is where I'm comfortable, is thinking at this level, thinking at the whole brain organ and thinking about how it's an organ that's really parcellated into a bunch of sub-functions. Just for example, we know that, there's a lot of things the brain does, but we kind of know there's an auditory part, for example, and a part that's in the back of the brain, the occipital lobe, that likes to do the visual things. And there's the sensory motor strip kind of right through the middle. So there's a lot of specific things that the brain likes to do. And if you get some localized dysfunction, on one of those areas, you didn't expect to see a problem with that kind of function. But the brain is highly connected, right? And so that's what this really beautiful image shows us. It shows us the white matter connections colored to demonstrate the directionality of their connections, right? Because there's connections left to right, anterior to posterior, superior to inferior, and all kinds of other diagonal directions that we don't have anatomical terms for. The brain is highly interconnected. So that means if you have some kind of focal problem in one place, the behavioral and neurocognitive manifestations aren't necessarily going to stay located or associated with what that brain area is for. So I'm pointing at kind of the frontal lobe, where you might see some executive dysfunction if you have problems with your frontal lobe, but that's connected to other parts of the brain. So you could end up seeing other areas not doing so well if the parts that are connected to it are not functioning at their best. And this kind of model really, I hope, drives that home in another way, if that's helpful. Is this is as we study the brain and its connections more and more, and we kind of begin to think about it as, there's nodes of the brain, places that have a localized specific function, and they are working together, they're connected to each other, connected to their neighbors, but then they also have these long range connections. So if you have a little trouble here, this is a good one to pick down in this lower right-hand corner, this node of the brain. If this node of the brain is having trouble, it's going to affect its neighbors, and it's got a few long range connections. So it's easy to begin to imagine how you can have a variety of neurological or neurocognitive complaints, even with sort of focal damage. But of course, when we think about that blood-brain barrier problem, that's everywhere, so we also have to think about, that may not be a terribly localized problem when we're talking about brain fog complaints that come from autoimmune disorders. But that said, it is heterogeneous. We don't really think there's any reason to look anywhere too terribly in particular, although I will say that thinking about neurovasculature is very helpful, and thinking about how vasculature has differential flow. There's places of greater vulnerability based on that. So it's complex, but again, what I'm here to really say is, I guess, when we're going to set out to figure out where is brain fog, what is most affected, this is where I'm at. I'm going to begin to think about different parts of the brain and their connections, and if there is some degradation to some aspect of it, what are the downstream and what are the system level effects? So to kind of get more specific and talk about the brain fog study, this is something that I've learned we do here at the University of Chicago quite well. We do these, there's this paradigm of the gluten challenge study. What a great opportunity to improve the state of our knowledge of, not only for celiac disease in particular, but just in general, how the immune system might directly impact a lot of things, but in this case, neurocognition. So we are beginning the study of exposing celiac patients to gluten. Well, they volunteer to do this, and the belief is that when they have this exposure, we're going to get that acute molecular event, that cytokine storm, and maybe this is what will help us understand brain fog. And very specifically, we're going to be looking at cognitive performance, really trying to hone in on what the brain fog really looks like, looking at brain network function through some MRI techniques, looking at mood changes. And we're also going to be getting some biological measures, serum and stool samples, and I'll go into the design of the study in a bit. But we're going to, in a very systematic way, be able to kind of control the gluten exposure and do a bunch of measurements associated with that, including the brain fog. And just to kind of plug who's doing the study, it's, I was kind of the last to come to the game, but it all got kicked off with Bana Jabri, Sonia Kupferin, who are, I think, known to the Celiac Disease Center quite well. And then Jean Dessetti, who's a psychologist as well here at the University of Chicago, well known for his work in neuroimaging and other diseases. And then I hopped into. And so just to kind of briefly let you know what we're going to be doing, we're going to be bringing in celiac disease patients who have brain fog complaints when they get accidental gluten exposure. And it's going to be a within subjects design. So you'll get a gluten meal in one kind of set of visits, and then they're going to get a sham meal in another set of visits. And we're going to be measuring, as I kind of said a second before, blood serum, we're going to get stool samples, test their cognition, have them report how they're feeling emotionally, and do some MRI brain function assessments. Excuse me. It's a pilot study, so there may be some imperfections you notice, but this is where we're starting. So here is the study design. Oh, excuse me, sorry about my coughing. So they'll be coming in 5 times. First is just the informed consent visit. And then they come another visit where they're going to get a meal, and they'll be blinded to whether it's the gluten meal or the sham meal. And then after they get that meal, we're going to be sampling blood, stool, and urine. And then, oh, I'm so sorry. After they get that meal, but really what we're going to do is going to have them go home, and then they're going to come back super early in the morning when their brain fog, we think, will really have been kicked in, and they're going to have had their GI symptoms if they've had the gluten exposure. We're going to put them in an MRI and assess their brain function. And then we're going to give them the neuropsychological tests, my cognitive tests, right after the fMRI. So we're going to try to, hammer away at the neurocognitive complaints right when they're kind of in the midst of their misery of their brain fog. That's the timing we're trying to get at. And that's kind of the design. And so let me kind of zoom in a bit more on these two pieces, the neuropsych assessment and the fMRI. Just to kind of comment that this is what neuropsychology is, just quickly in case you didn't know. Neuropsychological assessment is a field, a subspecialty of clinical psychology. There's adult specialists, there's pediatric specialists. And in general, what the field's goal is to just, we spend a few hours with people assessing them to figure out maybe what is a diagnosis or what are the functional associates of a diagnosis in terms of cognitive functioning, emotional functioning, personality, and so on. We take into account, case by case when it's a clinical practice, any contextual factors, including medical conditions, what's going on in their environment, and so on. And our tests have norms. Our tests are all, we have a sense of where you should be based on your demographic factors, basically. And that's what we do clinically. And it's a field that was really developed on the idea of wanting to see if we can give tests to people sitting at a table with them that help us understand what's going on in their brains, and it kind of goes back to the 1850s and early 1900s when, we learned things like, gee, if somebody has a massive lesion to their brain and then you observe a change, you might assume that the brain, function that they lost has something to do with the change you observed. So the very famous case of Phineas Gage, who had this metal pole kind of blast through his skull and it took out a piece of his frontal lobe. He survived and he changed massively in terms of his personality. He became rather a grump, everybody thought, to put it mildly. But this, this is one of these cases that we begin to really sort of think that we use to really sort of start to think about how brain behavior and personality can be understood. And then there were other lesions, very famous lesion cases that came along, like this patient HM, who had his hippocampus taken out as a epilepsy treatment, but he really taught us an awful lot about how the hippocampus works because he really had profound memory deficits going forward after that. And then the other big one was the studies of epilepsy surgeries. Penfield did these studies of sort of poking your brain while it was exposed for the surgery and kind of figuring out what, while the awake patient could tell you what they were feeling or sensing. And so it just began to map the brain in all these kind of interesting ways. And neuropsychology endeavored to try to figure out how to give people tests that could kind of predict those functions as we were learning about them. And just fun fact, a lot of neuropsychology, a good chunk of it was invented right here at the University of Chicago in the 40s. The chair of the psychology department at the time, Ward Halstead, helped develop a lot of this, along with his student, Ralph Reitan, who went on to become a prominent neuropsychologist himself. So just a fun little plug to let you guys know that. But through those decades leading up to the era of neuroimaging, which really came online in the 80s and 90s, and still today we're developing it as rapidly as we can. These neuropsych tests, these paper and pencil tests that you give across the table with patients, really, and I'm showing you kind of 6 of them in this slide. These are 6 neuropsychological tests, and this is from a paper where people were trying to really kind of say, okay, here, what are our tests really telling us when you give them to people with kind of known brain injuries? And the brain injuries were documented with neuroimaging. And this paper tried to kind of bring together the test performance and what the documentable brain injury was from the neuroimaging, and what kind of brain problems, what geography of the brain, if you will, can you say probably has the insult just on the basis of the tests using data from neuroimaging. So this is kind of where the field went to. This is 2009 that this paper came out. And then on top of that, what's really been happening in neuroimaging in the last decade or two is putting healthy people in the scanner and giving them tasks and asking and figuring out what brain networks are supposed to look like and to support a variety of mental functions. This is just a few examples, doing abstract thinking, paying attention, and so on. And so neuropsychologists understand this too. And so we kind of combine this kind of knowledge together as we test people and kind of begin to understand better, like if you're doing bad at a test, what kind of brain systems are probably impaired. And then finally, I would just throw out a plug for a really lovely technique in neuroimaging, which is resting state functional neuroimaging. Having people in the scanner doing absolutely nothing, as opposed to doing a task, but laying in the scanner doing nothing. And through this, we've learned a lot about, we've learned a lot about the networks that exist when you're doing nothing. And it's a very portable kind of paradigm to do in research. So A is a network that we think of as, we call this the default mode network. It happens to be one of the strongest networks that you can see when somebody's just at rest, but you can see a whole bunch of networks. Here's A through J of networks. Here's like an auditory network. Some people may recognize that this is kind of primary auditory cortex on the left and right side of the brain, just kind of active together. These things are correlating together as you just lay there in the scanner, and the scanner is taking pictures of you as you lay there. So this is another bit a useful tool for understanding brain systems and what they're supposed to do. And just, just let me indulge me while I nerd out a little bit and talk a little bit about how fMRI works. This is an example of one scan of the brain during fMRI, which is T2 star echoplanar imaging for the radiology folks in the crowd. But what we do is we collect a bunch of these while people are laying in the scanner, either at rest, like I said, the resting state scan, or during task-based. And what we're really looking for, I'm going to go ahead and bring in all the pieces of the slide. We're looking for brain activity during this, basically by looking at the amount of oxygen that is present in each little square. We divide up the brain into little squares, and we calculate, through the magic of the magnetic resonance imaging physics, we figure out how much oxygen is there over time. And so we're taking an image of the brain about every 2 seconds. So this is kind of a representation of that. And then we map out, so like, for example, in this little red voxel, this little square, how much oxygen is there? And over time, over each one of those images, we can kind of see how it's fluctuating. And in this example, say somebody's laying in the scanner, and for a while, we're having them look at circles, and then we change it to having them look at happy faces. And we might notice that for this little voxel, its oxygen content is kind of going up when it's looking at a happy face, and then it goes back down when it seems to be looking at circles again, and then maybe it goes back up when it looks at happy faces. So we might characterize this little particular voxel as more activated to faces than it is to circles. And so this is certainly kind of a sluggish approach to looking at thinking abilities, but this is the technology of fMRI, just to kind of give you guys a little glimpse into that. And I'm happy to talk a lot more about it if you like. And then just to kind of mention, how do we figure out what makes a brain network? These distant areas in the brain, like as an example, this area and this area, they both have their graph of how much oxygen is there over that time series, over that a picture of the brain taken every 2 seconds. And basically we just correlate those two lines to try to figure out how connected these two areas are, to describe that, whether those are a brain network. Very, very kind of simply. And there's a lot more sophisticated math, believe me, that goes into variations on how we want to describe brain networks. But so in a nutshell, we're deploying all of this for the brain fog study for celiac disease. What are we specifically going to do? We're going to have, when we give people the neuropsychological test, the paper and pencil test across the table, the battery I've come up with is pretty broad. We're going to test attention, learning, and memory. Can new information get in, and can you pull it back out if you did get it in? Processing speed, mental flexibility, so kind of in the executive function domain, and definitely going to be checking on mood, different types of mood. And then for the fMRI portion of the study, where people are going to lay in the scanner for about an hour, we're definitely going to do that resting state paradigm. And then we're going to have people do a couple of tasks, some higher order tasks of cognitive control, again, kind of a version of executive function. And then another one that actually brings in emotional functioning while they're in there. Just, I put it here for folks who don't know what it's like. This is an MRI scanner, and people are going to get, you go in there, and when you're in there, you've got this head coil that your head is in. And these are little mirrors that allow people to see a monitor that's actually located outside the scanner, but that this mirror is reflecting. And so you can actually see a computer screen that way and interact with it to do a task. And there should be like a little button box. This is not a great image of somebody doing fMRI with a task, but this guy, if it was a task-based fMRI, there'd be a button box this person has in their hand, so they can kind of push buttons to respond to the task, to kind of, show how fast they can respond to something or respond to a stimulus, whatever it may be. So that's just in a nutshell, quickly, how fMRI works. But so this is what we're going to do with people after their, hopefully their brain fog is set in from the gluten exposure or the sham meal. We're going to do it, at both times. And then I have one more slide, which is, this is not the results. We don't have the data yet, but I'm just kind of wanting to take people to that place of like, what might the results look like? What might we learn? This is a bunch of graphs that I come up with in the kind of work that I do. These are a few of my recent papers where I've looked at a few different things, but what we might be able to do is say, what is the connectivity strength in some given brain network, maybe just to kind of say the auditory network or the default mode network, between the gluten exposed brain and the not gluten exposed brain in celiac disease. And we might see, strengthening of connections. We might see more likely, I would say, weakening of the connectivity between these brain regions. We might be able to then kind of decide if that correlates, if those connection changes correlate with some cytokine level that we get from the serum, from that cytokine storm. We hopefully will get even fancier than all that and might do some more multivariate approaches to looking at the profile of test performance across the different neurocognitive domains, as well as the profile of cytokines that we're going to get. And by the way, I haven't even mentioned the microbiome, but we are going to have those stool samples. So we're going to be able to, take all of these measures and hopefully figure out, a variety of different relationships, describe a variety of different relationships between the post gluten exposed person and all of the events that occur and how their emotional functioning, their cognitive functioning, and their neural functioning seems to appear upon all this testing. So versions of this might be kind of what we see in the end. And that, I think, is the end of my slide. I forgot to do any fancier thank you, but certainly my appreciation to the Celiac Disease Center for inviting me to be here today and be part of the brain fog study. Thanks very much for your attention.
Thank you very much, Dr. Keedy. And you're definitely a part of the Celiac Center. It's always good to see a neuropsychologist in a zone which is not their comfort zone, but I think I know that you handled it so well. And it really is very interesting to see how all the other autoimmune diseases are sort of tied in, and we are learning from there, and hopefully we'll learn more about celiac disease with this study, with the neurocognitive and psychological sort of impact. And again, thank you so much for this study. I just want to remind people that this particular study is for adults. There's a different study that we're talking about, and we'll maybe mention it later. That would be for pediatrics, but this is just for the adults. So thank you very much. And also appreciate everyone keeping on time, because then we'll have more time for questions. So moving along, our next speaker is Lori Wellstead, who's a registered dietitian here in the section of adult gastroenterology, and is definitely the expert in celiac disease. And I've had the honor and pleasure of working with Lori for a few years now. She lives, breathes, passion, everything celiac disease, and really promoting health and wellness through nutrition education, whether it's celiac, IBD, IBS, abdominal pain, looking at adults with concerns about healthy weight. So looking at life really with promoting health and wellness. And of course, today we have the honor of having her here talk about discussing the truths and myths of the gluten-free diet and the various vitamins and supplements in 2022. I'm looking forward to this, Lori.
Thank you. Thank you so much for having me here today. I have no relevant financial relationships to disclose, and I will not discuss any off-label or investigational use of anything today. Okay, so there's so much to go over. So in my 30 minutes, I will try to tackle some of this. And like I said, there was so many things I wanted to add to my talk, and I just never have enough time. So we will discuss some of the very basic things about the gluten-free diet, because we know if someone's not adhering to the gluten-free diet and they're getting inadvertent gluten, that can absolutely affect so many things neurologically, psychologically, and obviously nutritionally. So it's just a very vicious cycle. So we're going to talk about some of these very basic things that can really help someone with their quality of life. We'll talk about some of the truths and myths about supplementation and vitamins with regard to celiac disease, and some of the issues with cross-contact, cross-contamination of specific foods. And again, just kind of go over balancing that gluten-free diet, because so much of it is very refined. We want to ensure that someone is eating a balanced diet overall and getting those vitamins and minerals, because we know that alone can absolutely affect somebody mentally, physically, neurologically. So gluten. So what is gluten? So again, gluten in Latin means glue. So it provides this structure. So if you think about, I think a croissant is probably my best way to describe it. So if you think about like the fluffy, the flaky, the crispy, the crunchy, like all of those qualities are in that just because of that gluten, that protein. So it gives a lot of structure, texture. As we know, it retains that moisture of the products. It can really extend fat and protein. So back in the day when I was an intern, a lot of even fast food restaurants contained gluten because it is a protein. So we do know like Vital wheat gluten, a lot of vegans consume that, and it is actually has more protein than meat has. So again, it was previously tucked into a lot of foods, and we know that gluten is toxic in celiac disease. So we do know that celiac disease is triggered by the ingestion of gluten. So we obviously are avoiding wheat, which is the biggest one, with so many different ingredients that could mean wheat. Rye is pretty easy to avoid because, again, as we know, rye is always tucked into things with wheat, right? A rye bread contains wheat. So overall, rye is probably the easiest thing to avoid. And then barley. We'll talk about some of the different little tips on avoiding barley, but that again is not a top allergen. So we'll talk about allergens in this discussion as well today. We do recommend doing oats that are gluten-free, certified gluten-free. As we know, oats are kind of one of the shady things when it comes to eating gluten-free. So we will touch on that today. And again, when in doubt, just try to leave it out. So if you think about the overall gluten-free diet, it could often lack fiber. So many of these things are refined and they might contain, tapioca flour, rice flour, potato flour, all totally safe and gluten-free, but not much fiber. So we'll talk about some different tweaks again to kind of infuse into your diet if you are on a gluten-free diet to ensure you're getting enough fiber. Obviously, it can be through fruits, vegetables, and beans and nuts and seeds, but if you are consuming grains, which ones to consider? B vitamins are also hugely deficient in some of these different swap outs. And then also, as we know, these B vitamins are important for your brain health. So this is definitely important to look at. Again, folate in females that are childbearing age. B12 is another one. Again, if someone has diarrhea and very loose stools, they could be, we'll talk about the absorption, but their B12 could be in the gutter. And even though the B12 is not absorbed in the duodenum, like all of it, so it's absorbed very low. So we'll talk about some of this along with, we know iron, calcium, zinc, those are often not fortified in these really expensive gluten-free products. And then we know variety. And I'm guilty of this too. I've been at the University of Chicago for almost 18 years, and I've had celiac disease for about 6 years. And at times I have 2 children. Sometimes I'm like, wow, my variety this week is kind of, nil. So these are things to continue to be curious about and be mindful on the gluten-free diet. So this is a great acronym that I think really does sum up the quality care of gluten on the gluten-free diet. So initially, it really is important, if you can, consult with a skilled dietitian. There's a lot of misinformation online, and you can really get a lot of food fears and kind of be pigeonholed in certain things that you're eating and not realize, oh, I'm not feeling good because X, Y, or Z. And so it's really good to have that, at least an initial consultation and some follow-up with a registered dietitian that is in GI. I can't tell you enough in those the years I've been at University of Chicago of people coming in and saying they saw a dietitian, she didn't know anything about the gluten-free diet. So you really want to see a GI dietitian, and it's really exploded in the US in the past few years with regard to registered dietitians that are specializing in GI. So I really encourage you to seek that out. Education about the disease. So really the true education, not just misinformation and fear. Lifelong adherence. So we'll talk about, I have so many patients that just say, well, it was really hard. And then they're not on the gluten-free diet for years. And that can really cause a lot of issues. And then really trying to identify initially and treating any kind of nutrient deficiencies. Because again, if someone is deficient in zinc, vitamin B12, any of these things, it's going to be hard to kind of catch up, and you will not feel well yet. And so all of these are really part of the whole picture. access to an advocacy group. So I am a co-leader of the GIG of Chicago. So, I thought when I was diagnosed, there really was not much in the city, Chicago proper, as far as advocacy groups. So we partnered with GIG, the gluten intolerance group. And so we have some different outings and things like that. And so that was important to me because even though I was an expert, I felt like there was really not a community of at least adults. So I think this is huge. And I think we have well over 200 people in our list that we respond with. And so we've done things in person, online, and really it's been a really neat way for people that are newly diagnosed and people who have been diagnosed for years to meet up and have that support. So I really think this is important because we can talk all day about like, the neurological and this and that, but if someone's not going to follow the gluten-free diet and they have celiac disease, it's going to be all downhill. So you have to find different ways to adapt to the diet, and it's not easy. I know that personally. And so I think it definitely has made me a better dietitian to work with these patients who have a lot of challenges with regard to the different dietary and GI symptoms that can occur, right? Just living your life. And then that continuous follow-up. So having a GI doctor, a registered dietitian, a GI psychologist is something that I highly recommend and has been very helpful in my practice. Okay, so the challenges. So we've talked about this so many times that, when you're first diagnosed, you have to mourn the loss of gluten. It is not easy. I would walk by food trucks and cry because they all knew my name. I was best friends with everybody at the University of Chicago. And you really have to find those coping skills of finding your favorite swap outs. And, it takes some time to really, get over that. Everything revolves around food. Eating out. So you can be getting gluten with the best intentions, right? You're putting your, your health in the hands of others. So again, sometimes patients, and we all, you can be, best intentions and you get gluten. So there's lots of challenges that arise upon the gluten-free diet. And then again, just, even with my patients trying to navigate, like if you are eating out, if you're going to parties, if you're traveling, different ways to navigate so that you're not hangry. Because I've definitely been there, and despite having things even on me, but you're sick of, your, bars or whatever you might have on you. You just want a warm meal or something that is legit. And then again, the quality of life, I cannot, I'm so happy that there's more research that's being done on looking at this quality of life, because when someone is very, very vigilant and super, super anal about the gluten-free diet, that can really negatively affect their social and emotional wellness. And so it could be a very snowball effect, right? So it's great to be very vigilant and be very mindful overall, right? We don't want you just, chugging beer on Saturdays or eating regular pizza just because you had a bad day. But we want to find that balance, right? It's like walking this tightrope, because we know that extreme vigilance is associated with anxiety and depression, but we also do know that if someone's cheating on the gluten-free diet, that can also affect that anxiety, fatigue, all of that. A recent survey that was just at Digestive Disease Week last year, fellow dietitian Jessica Lebovitz, she looked at those with celiac disease, and up to 68% reported, major and moderate impact on their social life. So this is really, really important. And as we know, quality of life is key. Because oftentimes these patients will just go off the diet and again have so many other things be diagnosed in the meantime and not looking at the core of the issue. So again, we've talked about this today, but all those extra intestinal manifestations. So I talk about this with celiac disease and with my inflammatory bowel disease, the Crohn's and colitis. Patients that you have these extra intestinal manifestations that are outside of your intestines where you actually have the disease, right? So you can have this horrible, the brain fog, migraines, headaches. Sometimes that's the only symptoms my patients have are just horrible migraines and headaches. That was the only thing. Neuropathy. I cannot tell you how many patients that is one of their main symptoms as well. Even that gluten ataxia, the muscle coordination. We've had some very interesting cases at the University of Chicago coming from small towns and seeing this. So just going on the gluten-free diet really, really has helped these patients, but it's been very eye-opening. And then as we talked about, all these different psychological manifestations that can come, and then that lack of interest in food. When you're mourning something, think about mourning, the loss of a family member. Sometimes you're not hungry, you're not interested in food. So there's so many things, and this is why I think, really having a GI psychologist, if you can find one, that could be very, very helpful to help tie a lot of this in. So what do I do with my patients? So again, we do recommend obviously a strict gluten-free diet, and then really reviewing the diet and the lifestyle with a fine-tooth comb. Like, how often are you actually eating out? Like, what, looking at your kitchen and kind of seeing, okay, where might be some cross contact or different ways to modify to really help, again, improve your quality of life and really help you adhere to the gluten-free diet. Because we can talk all day about this and that, but if you're just like eating gluten and not really realizing the impact, it's just this vicious cycle. And so again, then looking at those considerations for supplementation, does someone need to be on vitamin D? Is there vitamin D in the gutter? Because we know if their vitamin D is low, they're not going to absorb calcium. That's going to directly impact their osteopenia that they might have in their 20s. So we really want to look at this on a case by case. And so I wanted to, this is a great slide from my mentor, Beth Wall, who's a dietitian at University of Chicago. So this is looking at like where are these vitamins and minerals absorbed in the GI tract. So again, if you look at the duodenum or the duodenum, that's just below your stomach. So you've got your esophagus, stomach, duodenum. In that area, what is absorbed there? As you could see, a lot. And so again, iron, if someone's anemic, that is the main area where iron is absorbed. So if you are inflamed in that area, again, that's going to affect oxygen getting to your blood, through your bloodstream if you're anemic, and that's going to affect, your overall wellness. So there's so much to this. So many of those are affected, not only for brain health, but your overall wellness. You see your fat soluble vitamins, the vitamins A, D, E, and K are all starting their absorption right there. So we know if you have a Berber hair of carpet in your duodenum instead of a nice long shag carpet, which is what you want to absorb your foods, a lot of those vitamins can be in the gutter. And so those are things to be mindful of. And again, it's all about being curious about your overall nutrition, because I think it's not one size fits all. It's looking at your specific symptoms, and really, again, you have to be your own advocate. I know that myself from my own experience of being diagnosed. And then, as I said here, your ileum, which is the last part of your small intestine before your colon or your large intestine, that's where a lot of things, including, vitamin B12 is absorbed. So if someone does have loose stools for a long period of time, that could be depleted, and that can absolutely affect so many symptoms that we see. So I did want to touch on this because we see this a lot. So if you think about that shag carpet of hair, there are all of these little enzymes that will break down foods, right? So we have enzymes that break down sugars and fats and proteins, and then we have these little lactase enzymes, and they break down the lactose molecules. And so in celiac disease, when you're first diagnosed, you can often have some lactose intolerance prior to the diagnosis, right? You might say, oh gosh, yes, milk always bothered me. That was something. But upon going gluten-free, that could actually improve. Now, for some people, it still doesn't improve. Okay, fine. But it doesn't mean you need to be 100% dairy-free. So I wanted to touch on that because oftentimes people think that they need to be, gluten-free, dairy-free, corn-free, soy-free, this free, that free, and they don't necessarily have to be, right? So if you think about things like butter, hard cheeses, those are lactose free. But yes, things like milk, ice cream, cottage cheese, those have large molecules of lactose. The content of lactose, which is the sugar in milk, is going to be pretty high. And so you might see that you're having a little bit of gas and bloating because you don't have enough enzymes to really nick those molecules down. So you're not going to have, a beer brewery in your colon after ingestion. So oftentimes patients will simply just take a lactose, like a lactase enzyme prior to eating. And so there's so many different ones on the market. There's generic ones, and you can take those just right before you eat, and that can help to resolve that if you are worried when you're eating out. But I did want to touch on that because there's, again, so much misinformation. So the common nutrient deficiencies. So as I said, vitamin D and calcium is huge. I provided some of the presentation that you might see, and then those nutrient dense food sources. As we know, vitamin D really is not in the food supply very much. Like mushrooms are a pretty good source, and so are egg yolks, but you have to typically supplement or get it through the sun. And we know in the Midwest, we are not getting much from the sun. And when we do, people are like lathering up with their SPF. So not absorbing much vitamin D there. Again, with anemia and with iron, again, if someone is anemic, they could have brittle nails, they could feel very fatigued. There's so many different symptoms, right? So again, making sure to check those levels of your iron studies, just to ensure that you are in a normal level. Some people do need to supplement for a short time on iron or doing a multivitamin that first year, and then are able to come off of it once they're absorbing normally and healed. So I just wanted to have this as a reference so you can see some of the correlations, some of the nutrient dense food sources. So again, some of the vitamin and mineral considerations across the board, even I'm working on a study right now with other registered dietitians, and across the board, not everyone is recommending a multivitamin with minerals, right? So at the University of Chicago, we typically recommend taking one in that first year after diagnosis. It's not saying you have to take one for the rest of your life. Now, again, historically, I've been here almost 18 years. We used to say everyone has to be on a multivitamin. You can absolutely be on one. It's not going to be harmful. But if you are eating a really balanced diet, if you are really mindful of those, some of those ancient grains that will have a lot of the vitamins and minerals that the white stuff that's gluten-free, that's not fortified, you could probably be fine and not have to take a multivitamin with minerals. But if your diet is limited and doesn't have much variety, we would typically recommend that just to help to kind of replete and get those vitamin and mineral levels back up to par, and then moving forward. So again, iron, calcium. Again, we usually recommend doing a bone mineral density so you can see where is your baseline. Are you osteopenia in your 20s, or are your bones looking great? To really see if we want you to supplement with calcium, vitamin D as well. Again, in the Midwest, most of my patients are often having to supplement with vitamin D at some point. And so really just being mindful of some of this can help with the quality of life, right? It's all about your day to day. You could be working, making all this money, but if you feel not so great, this is really the key to life, right? You want to have vitality, you want to feel good. So again, looking to see what your B12, and if you do have to supplement, that is something that again is water soluble, just comes out in your urine. So you're not going to overdose. Now, again, vitamin D is also very, very hard to necessarily overdose on. Everyone is usually deficient, but I wanted to just touch on this. I could go on more about probiotics, but I wanted to touch on the fact that you do want to be aware of taking probiotic supplements. Not all of them are necessarily gluten-free because of the growth media. So Columbia looked at this, and they looked at a variety of probiotics, and some of them were contaminated with gluten. I do not know what are the brands, but I do recommend patients, if their numbers aren't coming down, if their gut's not healing, we want to look at, are you taking a variety of probiotics that could have a growth media that can contain gluten? Because as we'll talk about, if things are hydrolyzed with this growth media, it's going to be really hard that it's going to look gluten-free, but it's not. So I'll touch on that in a second. I wanted to touch on this really interesting experience I had with one of my patients. So she was diagnosed in 2016, and she was 42 years old. She had terrible brain fog, twitches, severe anxiety and depression, and it was diagnosed 10 years prior. Horrible fatigue, joint pain, constipation, never had diarrhea in her whole life, she claimed, always constipation, and rashes. Her weight was stable. She was 140 pounds and her BMI was 22. She did admit at that visit, she ate some Hostess donuts the day before. She was just stressed out. Everyone else in her house eats gluten. So she had Hostess, donuts. And, she does eat out of shared fryers. She was from a small town, and she, didn't really think much of it, but noticed that she did have some nausea after she had it, and she did have some joint pain. So I educated her at that visit, again, to really watch those, avoid shared fryers and really to kind of buckle down and be on this, strict gluten-free diet. And we had, some, email, phone call follow-up in the interim, and she was doing much better and, confident on the diet and whatnot. Well, fast forward to the pandemic. March of 2020. And this is when, before we even were able to do video calls, and I had to do a phone call with her. And, she's crying, she's up 40 pounds in the past 4 years. And, new antidepressants, her anxiety and depression was, just off the wall. And she was feeling terrible. She admitted that she was eating gluten for the past 2 years, basically every day. Just, yeah, Lori, I can't help it. I couldn't just avoid it. I ate it every day. Now she's having terrible diarrhea, just, loose stools daily. So again, we talked about, really strict going gluten-free, very strict, at that time to see if this will help. I had a baby 2 months later. I was on maternity leave. She didn't really follow up until just this past January. And she went back on gluten again. And so the past few years, again, she was just, if she had a bad day, she would have some gluten. But now she had some even more severe symptoms of this brain fog, the fatigue, memory issues, totally. And again, she's only 48. Total memory issues, neuropathy to the point where her whole body was buzzing, which I haven't really heard that in my practice. And these tics that she would have. She was feeling terrible in January. So we really went through the diet again, and I gave her some, I'm very positive, and as you can see, I have a lot of energy. And so we talked about, even my own, challenges when I went gluten-free, and, we really went into like, what can we do? So this is going to be easy peasy. Let's not think too hard about this. Let's go strict. Like, I found some good swap outs for her favorite foods. And she had some improvements just a month later. She was like, Lori, I feel so much better. I am a new person. I'm like, okay, good. Let's stay on this path. A month later, again, on a very strict gluten-free diet, she was already seeing improvements with her, the brain fog, memory. Her energy was way better, more sustainable, and she had less neuropathy already. So I'm planning on following up with her in the near future here. And so I'm hopeful she will stick to the diet. So again, it's all about finding, what's going to help someone adhere to this diet. There is no drug for this disease. And so it's hard. We can, lead someone, that way, and they just might not stick to it. So I think that is some proof in the pudding of just a recent patient that just going on a strict gluten-free diet for most patients can really improve some of these symptoms. Again, it might not improve all of it if someone's been, cheating and eating gluten for years and years and years after their diagnosis, but it could make some headway and again, improve your quality of life. So again, just some background on the gluten-free labeling law. So back in 2014, it was in FDA foods, which again is cookies, crackers, cereals, pasta, those dry foods, anything that's under 20 parts per million in the end product is gluten-free. So they could throw on their gluten-free, no gluten-free, gluten, without gluten on the label, and it's, okay by the law. It is supposed to cover cross-contamination in imported products, and it doesn't require testing though. So again, the FDA does not test these products, as you may or may not know. This does include those packaged foods, vitamins, and supplements, but does not cover alcohol, medications, cosmetics, or USDA. So on the whole USDA thing, so we've got the FDA. So again, your cookies, your crackers, your cereals, your pasta, that by law will tell you, and you've seen on many labels, if it contains wheat, it will either say wheat in parentheses or below contains wheat by law. Now, if something's under the USDA, it does not necessarily have to do that, though now up to 90%, if not maybe more at this time, is actually following the guidelines of FDA. They're being more transparent. But to reiterate, the USDA is going to be things like, canned soups, canned, anything that has meat in there, right? So it could be a canned soup, a canned chili beans, or, chili that has meat, and it's under USDA now. So just being mindful of that. Again, broths, bouillons, things like that can often be a challenge. So you want to purchase some of those products that actually will state gluten-free if they have some of these, if they don't say gluten-free on some of these labels, it's sometimes not as clear as something with the FDA, with the labeling. Okay, so what does 20 parts per million mean? This is Trisha Thompson, who's the gluten-free watchdog. She's the guru, and I really love this because she is showing you the volume. So it's 20 parts per million is 20 milligrams per kilogram, 2.2 pounds. So it's a very small amount, but again, it could add up in certain foods, right? So you want to take note that this is not, it's the weight of the gluten that's important, okay? So these are all samples of 1 ounce servings, which are a 0.5 milligram of gluten, if that was 20 parts per million in that product. So as you can see here, the pasta, it's a small amount. So if something is, say, you know, cross-contaminated, it's a small amount. It's because it's so dense. As you can see, the cereal's a little less dense. Obviously, the medications, you'd have to have a lot of those pills there in order to ingest the 20 parts per million of gluten. So yes, medications are important, but we still want to be mindful that that's not going to be sometimes as risky, sometimes in that portion as it is for some foods. As you can see there, that's like a paprika or something. Now, again, in 1 serving, that could cause that would be 20 parts per million. But again, if you're making a dish, you might have just a pinch of that. So I think it's very important to put this into context. And I think as these years go on here, we're going to have a lot more on cross contact. She did a shared fryer study. I didn't have enough time to touch on that, but again, really to back up some of these claims, because we do recommend sometimes being so conservative on the gluten-free diet and being very mindful about it. But we do want to see where can we kind of loosen the reins, if at all, right? And that this is going to be something that you could still adhere to and not be as worried about. So I think that will hopefully give you at least a visual aid. To help, another visual aid that Trisha actually broke up this bread here so you could see what is 10 milligrams of gluten. So again, the big hallmark study that's from Italy, which we need to have more of these, again, to really look at the ingestion, how much you can have. So they looked at these individuals and they gave them 0, 10, or 50 milligrams of gluten over 3 months. They found that 50 milligrams of gluten on a daily basis caused that villus, the villi, to be atrophied and to have damage. So as you can see here, this is 10 milligrams of gluten. So again, it's a significant amount versus someone that I might see that says, oh my gosh, what if I touch a doorknob that someone touched that had gluten earlier in the day, right? And those are things we don't need to freak out about, right? Again, when you're first diagnosed, I was in that realm too, right? That you initially are like, everything is like a black light, that you're scared. But again, this is actually a fair amount, and you'd have to multiply this by 5 on a daily basis to have that gluten, to induce that damage from the gluten. So again, what about oats? I wanted to touch on oats. There's so much to this, but we know that there is a small subset of patients, actually a study that was done, up to 22% of patients with celiac disease developed a reaction that's very similar to ingesting gluten, which avenin is the protein that's in the oats. And so if you think about that, that's, you know, a little chunk of the patients. It's 1/5 of the patients with celiac disease could develop this reaction. So again, that's something to keep in mind if someone can't tolerate oats and they know that. They just say, oh, I just don't do well with oats. Okay, fine. Like, there could be a reason, right? Now, when it comes to consuming oats, we don't want someone to just go, you know, buck wild and consume oats in every single product they're having all day long. It can actually, it can add up. So again, the Academy of Nutrition recommends 50 grams of gluten-free oats daily. And in the serving, it's about a 1/2 cup rolled, a 1/4 cup of steel cut, a packet of instant, or a 1/2 cup of granola. Now, again, as I mentioned before, we recommend doing, you know, gluten-free oats, certified gluten-free oats, and then there's purity protocol oats, which is kind of the top tier, never cross-contaminated, never grown in a field with wheat, never processed, shipped, any of that. So there's different tiers to oats. And we do know, as I mentioned, is that the risk of cross-contamination in oats is way higher than regular old foods that are labeled gluten-free. So we want to be mindful of that. It's all about the portions, the type of oats you're eating. And then lastly, just be mindful of oat milks. Oat milks are very, very hot right now, as is oat everything. And they're tucked into a lot of foods. And so Trisha Thompson did a recent look at some of these oat milks. And, in the serving, because you have to remember it's a liquid. So the volume, it's very, so a serving would be only 8 ounces. And in an 8-ounce serving, now again, if you go get a latte, you might get a 16-ounce serving or a 20-ounce serving, which again, very easy to do, right? Now, if you do a 20-ounce serving and each 8 ounce has 12 to 15, or I think it was 12 to 13 parts per million, that could add up, right? So you could slowly be actually getting in some gluten. So again, when I'm talking to my patients and we're trying to figure out where might they be getting inadvertent gluten ingestion, looking at those kind of things, right? So again, down to the nitty gritty of like, well, what are you drinking in your latte? Are you drinking oat milk? Oh, you have 2 20-ounce a day. Okay, that could add up, right? And again, just each person is different. Some people are not eating any oats. Some people are going wild and having oat everything. And again, oats are very healthy overall. Their nutrient profile is great. And so if someone can consume oats, that's great. But again, it's all about finding that balance. Because again, as Americans, we're kind of all or nothing when it comes to different diets and different changes, right? We get into a rut. So again, where are the sources of cross contact? So anything that goes in or around the mouth is suspect. So again, read those ingredients as things change. So read those labels. Again, with contamination in your own kitchen. So again, for myself, I feed my children gluten, but I don't eat gluten. So if I'm like making something for them, I make sure I wash my hands, right? And that could make you kind of feel like a little like overwhelmed at times. And for myself, I'm like, okay, make sure I wash my hands. Like, whoa, I just made, so again, just washing your hands is all you have to really do, right? So having clean hands, being mindful of your prep area. If there's a bunch of crumbs on the counter, don't just slap your gluten-free bread down, right? So obvious things. And then condiments. So be mindful, obviously, of your condiments. If someone's, dipping into your butter or your peanut butter or whatever it might be, if you had a black light, gluten would be all in there. So having squeeze bottles, having your own butter or doing things, whatever it might be, just to make it seamless and not so overwhelming. And then again, I have italicized because some of this stuff still needs to be studied, but being mindful of some of those cooking tools. So again, toasters. Now, if you have a toaster oven, it's a little easier to watch for cross contact versus like a toaster. Now, yes, there's the recent toaster study, and you might not get much gluten in one piece of toast versus another, right? So there's a lot of things that depend that are fat. There are many factors in this, but I think there needs to be more studies done. So I still recommend patients just be mindful of their toasters, especially when they're newly diagnosed, just to be, aware. If you have an old, crusty toaster, like maybe get a new one. If your colander is, if you think about a colander, gluten is glue. So again, you pour hot water with gluten pasta, it gets stuck in those little tiny crevices. So it's very hard to clean those out at times. So oftentimes, getting a new colander could be something just to have, and you can use that other one because oftentimes patients are washing their fruits and vegetables in their colander. Well, great. Your son just made gluten pasta from there and it wasn't really cleaned out well, right? So just being mindful of those things. And again, not going neurotic and going down the rabbit hole, but just being aware and curious of those different tools in your kitchen. Cutting boards. Again, this is a huge conversation in the study I'm working on right now is cutting boards. Like, we do tell patients to be mindful of cutting boards if they're old, crusty wooden cutting boards, really watching those gouges, right? Again, there are no studies on how much gluten is going to be in a cutting board. This is just overall conservative recommendation. So again, just being aware, if you have an old cutting board, maybe getting a new one. So other things to keep in mind is like muffin pans, cast iron pans, some of those wooden utensils, again, an old wooden spoon that you always use for your pasta, maybe getting some new ones. They are porous, but again, there's no money to do studies on this stuff right yet. Like how much gluten is in your wooden spoon. So also just having those, conversations about, school, daycare, eating out, all of those different things where the cross contact might occur. So when it comes to things being gluten-free, as I mentioned, there are a variety of different certifications because again, this is third-party testing because the FDA has bigger fish to fry. They're not going to test every single food that's out on the market that says gluten-free. So there's GIG is the gluten-free certification organization. You can see their old logo and then their newer logo. I think a lot of people are using that. It's a very, the old one. The Celiac Support Association, their logo you've often probably seen on foods, the gluten-free certification program, and the NSF certification. So as you could see here, all of them are actually under the 20 parts per million. So that's kind of another like safety net again for some things, but I'm not saying that you have to buy everything that's certified gluten-free at this point. So I wanted to make that clear too. Hydrolyzed protein, just wanted to quick touch on this because this is something that often comes up because there's so many popular like gluten removed beers, right? I didn't have enough time for this either, but we did a study looking at this at the University of Chicago, and bottom line, still those gluten removed beers we do not recommend for celiac disease. Barley malt vinegar, people might have with fish and chips, probiotics, again, so when something is hydrolyzed, so imagine you have like a long strand of DNA. When they hydrolyze it, they cut it, right? So they can do an ELISA test, like a blood test on these foods, and it can look totally gluten-free. But the problem is when you're breaking up the DNA, you're not going to have an accurate reading. So hopefully that makes sense. And so that's where it comes with some of these hydrolyzed foods. It's a little bit shady because they might say, oh, this is totally gluten-free. I've gotten, little reports from different breweries saying this is actually gluten-free. We've tested this with this ELISA testing. And I'm like, no, you use they use this to break up the DNA. So it's unfortunately not legit. So just keeping that in mind, again, about those hydrolyzed proteins. Again, a lot of words here, but the common pitfalls that I see, again, some of those different foods, like, their broths, their bouillons, if they're taking communion, again, brewer's yeast, fried foods, imitation seafood. I have a lot of young patients that are going out for sushi and just getting like a California roll, like not thinking twice, but not realizing that imitation seafood is pure gluten because it's, full of protein. And again, some of those different, malted beverages, marinades, Play-Doh for children, soy sauce, as I mentioned. So again, when you think about soy sauce, all those different ingredients that are made with soy sauce. I know I'm out of time here, so just different grains, some different recipes to consider. And then just remembering if you have things that are very white, like white rice, white pasta, they don't have as much nutrients as some of the different whole grains like quinoa or some of the different new lentil or bean varieties. And then my last slide here, just on that balancing the gluten-free diet. So I kind of took the My Plate and added some gluten-free considerations. So again, in conclusion, a lifelong strict gluten-free diet is really the only treatment at this time for celiac disease. I hope you enjoyed my lecture and look forward to questions.
Lori, thank you so much. I'm not going to let you go anywhere just yet. And I would invite Dr. Sarah Keedy and Dr. Hillary Jericho to turn back on your screens. We have a tremendous amount of questions to get to. So I'm going to let Dr. Verma, if you'd like to kick off our first question.
Sure, thank you. And thank you very much for everyone who's sent in the questions. If we can stop sharing the slides would be great. And it really has been fantastic involvement with the group. And thank you very much to the speakers as well for giving up some of their Saturday. So I'm going to try and bring up some themes of questions. And I'm going to start off with you, Dr. Keedy and Dr. Jericho. A lot of interest about ADHD, panic attacks, and, looking at those kind of symptomatology, bipolar, where would you say celiac disease fits into it? Where are we with that currently? Where do we go with that? So I don't know, Dr. Keedy, if you want to bring from your experience as a neuropsychologist, and then Dr. Jericho can join in, sort of a tag team in terms of where are we with that and celiac.
Sure. I saw that question come in and I did some quick searching myself, but I have to say, I don't in a handy way know what to say other than people are just wondering a lot about it. I think, there's studies where they've tried to find out if celiac disease is more common among bipolar patients. And I'm not sure that that's panned out, but are bipolar patients generally less healthy in a variety of ways? Yes. So just these systemic dysfunctions that go along with disorders, like, I'm not just picking on bipolar, but this would apply to depression, schizophrenia, a variety of major psychiatric disorders. And I definitely want to say some things about anxiety and panic attacks in this stuff in a bit and how that relates to GI symptoms, but maybe I'll just give the floor to Dr. Jericho now to make any comments she might have on the general topic.
Yeah, no, this is definitely a question that is brought up a lot, and I guess I'd probably actually divide it down into two distinct entities, one being more the anxiety, depression, panic disorders as one entity, and then things like ADHD, ADD, autism, that subgroup of diagnoses as another one. There's been many questions along the way about, do we see higher rates of celiac disease in patients with things like autism, ADD, ADHD, bipolar, those sorts of disease entities. And at the end of the day, at least from my literature understanding, there have not been great distinct correlations between having celiac disease and developing these disease entities. There's lots of questions about, these individuals going on a gluten-free diet and it helping symptoms. And definitely, I think people do see that on their own personal experience. And again, coming back to what Lori has gone through in amazing detail, if it's done in a healthy way, in a balanced way, the patients are getting all the nutrients that they need. They're not getting too many processed foods that are going to be high in fats and sugars and things like that. And the diet's being done in a healthy way, and people feel like it's helping those disease entities, then by all means, we would never say not to do it if individuals feel like that's helping. But as a whole, at least from what I've seen in the literature, there has not been an absolute correlation between having these disease entities and higher rates of celiac disease in this population. Going over to more the anxiety, panic attacks, depression category, we definitely see very high rates of those disease entities in our patients with celiac disease. And there's a lot of different speculation as to why this is. It's thought that potentially prior to the diagnosis, it may be secondary to some of these vitamin deficiencies, and as a whole, just making people feel more fatigued, not having as much energy, different symptoms along those lines that contribute to those symptoms. And then once they're diagnosed and they're on the gluten-free diet, well, a lot of those vitamin deficiencies may improve. Then you kind of get into that situation that Lauren was also getting at, and Sarah was as well, that psychosocial impact of being on the gluten-free diet and what that means for these individuals at school, at restaurants, at camps, at other social events. It can take a big toll on them. Like Lori was saying, eating is a huge part of all of our lives. It's something we deal with every day in every situation. And certainly, while people understand celiac and it is so much better known out there, it still can have a huge impact on individuals from that social and psychological viewpoint. And so we do see very, very high rates of anxiety and depression and panic attacks in our patients. We actually did a study a couple of years ago that was finally published, I think last year, looking at rates of depression in our patients with celiac disease. And the numbers were incredibly high, way higher than we imagined, and corresponding with those of patients, having actual psychiatric diagnosed depression. So we definitely see that, and for many, many different reasons. And I think, as Sarah and Lori both pointed out, I think the psychological aspects of celiac disease is something that's very, very important that we address and don't overlook, and ensure patients know we're there to help them, and there's lots of resources to help them, and that what they're feeling is not unusual, and it's very, very common in our patients.
So thank you. So I think one of the things I would just want to make an emphasis is that there are some anecdotal studies that do associate ADHD, ADD, and so on with celiac disease. The most important thing would be to really have a discussion with your team, with your clinical team, and not just go on a gluten-free diet. It would be so important to have the testing done, to do the testing for celiac disease. And of course, if the testing is negative while you're still eating a gluten-containing diet, then perhaps go down the path with more like sensitivities and those sort of discussions. But again, it sort of reflects on more studies are needed, more organized prospective studies are needed for us to sit here and say, 20% of people have this. There are several anecdotal studies that have been published that talk about all of these conditions with that. But Dr. Keedy, you had something that you had wanted to add as well.
I just wanted to say for the question around particularly like panic, since that's been brought up, and other anxieties, that it's a chicken and egg question, no doubt, with celiac disease. But what I would say in a very practical way is if you're in that situation where you have both, there's no reason you can't actually address it through psychological treatment, through cognitive behavior therapy, because those GI symptoms absolutely can trigger those panic attacks in a way you don't really detect. But that's absolutely what GI psychologists are great experts at. And just to kind of address a bit of additional questions I'm seeing come in, GI psychologists get that special, we're all clinical psychologists, and then there's a subspecialty called health psychology, which are the psychologists who really get good at operating in medical centers and working with people with health conditions. And then a subspecialty of health psychology would be being a GI focused psychologist. But if you can get your hands on anybody who can identify as a health psychologist or a GI psychologist who did a special fellowship, like 1 or 2 years of training in GI, that's what makes you a GI specialist. But it's absolutely, many psychologists know how to treat panic. And it doesn't matter if it started with celiac, you can definitely get that treated pretty straightforwardly.
That's fantastic. Well, thank you, Dr. Keedy, and I love how you just addressed a few of our questions. As we move to our next topic, I'll look to Dr. Jericho and Dr. Verma. Can you talk about the recommendations and best practices for first-degree relatives receiving a celiac test?
Sure, I guess I'll hit this first. Every gastroenterologist out there does things a little different. As a rule of thumb, and I think I brought this up when I mentioned my patient before, many of us will screen these first-degree relatives. It's thought that, up to 15% of first-degree relatives may have celiac disease. I had actually seen another question in that Q&A about all those first-degree relatives who aren't screened. Are there studies out there showing how many of those individuals are being missed? There are some studies out there now that are specifically trying to screen all the first-degree relatives and are actually finding rates that are higher than that 15% mark. So it would lead you to believe, that the rates are probably higher because a lot of those first-degree relatives are not being screened and are being missed. And sometimes, it may just be that gastroenterologist isn't familiar with, the recommendations that are out there, which are to screen those first-degree relatives. Ordinarily, many of us will do the screening right at baseline when the diagnosis of celiac disease is made for the patient. And then many of us will continue to screen, again, depending on the gastroenterologist at different time points moving forward. I typically repeat screening every 2 to 3 years indefinitely, because we all know that celiac disease can occur at any time in someone's life, from that first exposure as an infant all the way up into the 90s. And a lot of our patients, and many patients I've had, have been picked up and completely asymptomatic. So just because you don't have symptoms doesn't mean you shouldn't be screened. And just because you don't have symptoms doesn't mean you shouldn't be treated. I've had a number of parents who I screened, and I am very willing to give those lab slips to anybody. Just because you're over 18 doesn't mean I won't test you. I will. And a lot of those parents had no symptoms, but unfortunately they did have celiac disease. And when they looked at things like bone density, they actually had thinned bones because of that long-standing vitamin malabsorption. So even though they didn't feel bad, again, a lot of those deficiencies are occurring at the level of the gut, and all the more reason that, it is very important to treat these individuals, even if they're not having obvious symptoms. But, unfortunately, not all gastroenterologists do screen. So I think that would be a very good practice, that they should be screened, because I think we are missing those asymptomatic patients if we don't. But there is always that situation too. I have a handful of parents that, despite me nagging them up to wazoo, some people just choose not to. And so, because of that, we probably are missing individuals who have celiac and are just asymptomatic or would choose not to get tested. So again, the rates probably are higher than that 15% that's perceived. And we're just missing those other individuals. Now, turn over to Dr. Verma as well.
So thanks, Hillary. There are no official sort of recommendations. And I think that's what causes the problem for a lot of clinicians, is because there is nothing official. And often people feel like, should I really subject this person to a blood test and a lifelong gluten-free diet? So I think that goes from the heart in that way, but perhaps not should not be that way. So what do I do? So I'm a pediatric gastroenterologist, and so I screen all my patients' siblings and siblings, not the parents, siblings. I screen them once a year till they reach puberty. That has been my practice now for almost 30 years. And part of the reason that I will screen on a yearly basis is because it's very difficult. It's very easy to forget. Is it the year I should be screened? Is it not the year I should be screened? So every summer, the whole family goes. It's a family event. Get your celiac panel done. Or it's wintertime, get your celiac panel done. And the reason I pick puberty, again, is if in those asymptomatic patients, if you miss that window, you miss the window of growth. So for me, every sibling that has not reached puberty gets screened every year. So that's just a given. And very important that when you are suggesting as clinicians to get the screen done, that you get a history from the family in terms of how much gluten is that child eating. Because again, if you have 2 or 3 members that have a gluten-free diet that they're following, the amount of gluten goes down in your diet. So the second question to ask is how much gluten? And if they're not eating a lot of gluten, then before their scheduled blood test, they increase the amount of gluten for several weeks and then get the blood test done. So that's for the children. And then the parents, yes, I write the lab slips for them as well, just like Hillary does, because sometimes it's kind of hard to go get an appointment with your internist. So let's just do it one-stop shop kind of thing. And I will recommend that all the parents get screened as well. Sometimes they do, sometimes they don't. And the parents, I go with it every 2 or 3 years. Now they could join their children and get screened every year as well. I have a family event, since celiac disease is a family event. So that's the sort of thing. Then the recommendation is also first degree and second degree relatives. That gets even harder to put it into place, but very important that you encourage the parents to tell their siblings, their parents, and so on, that there is a higher likelihood. So again, that is something that you discuss. What we did not discuss, since that was not the topic of discussion today, is there are genetic tests that can be done, and some people opt for that. And the only thing to remember is if you are genetically negative, then you don't have a chance of developing celiac disease, or a minuscule chance. Then you may not need those screenings. So that's a topic for another discussion, but that is a blood test that can be done. So Rachel, sorry we took a long time to have this.
That's okay.
discussion.
I want to turn this over to Lori. I have a quick question for you specific to liquid supplements. I know you talked a lot about deficiencies. Is there what are your thoughts on for better absorption versus a pill? Is a liquid better than a pill? And just give us your thoughts on that.
Yes. So I think for some patients, again, if they're already having some malabsorption issues, they can absolutely do a liquid. Sometimes those are pretty potent. There's also, I noticed there was another question about sublingual. So again, for B12, that means you would put it underneath your tongue. So there's little pills that would dissolve underneath your tongue. So sublingual B12 or doing liquid vitamin or supplement, that would be fine. And again, sometimes that's an easier way to get things down than taking the pills for some patients. The only thing I would be mindful of is that sometimes the liquid supplements could have things that like sugar alcohols. So things like sorbitol, xylitol, mannitol. So just checking the ingredients. So if there is anything with an OL, that might cause you to have loose stools. So you might not be getting gluten, but you might be getting some of those fermentable things. But otherwise, liquid supplements are typically well tolerated.
Thanks, Lori. So Dr. Keedy, we are going to go a little bit into the fMRI world. Let me talk about myself. When I think about fMRIs a long time ago, it was more thinking about irritable bowel than celiac disease. What is it on an fMRI that one can look at and say, this is more a response that is from a celiac gluten standpoint? Is it a response from some other condition? How do we interpret these fMRIs in the context of celiac? And when you look at that, do you look at different sort of types? Because, with celiac disease, we don't have all of us don't have the same symptoms. So some have different symptoms and so on. So how much of information can one glean from there that would differentiate with celiac and other conditions? So maybe I'm putting you on the spot, but maybe you can educate all of us on that.
I know you're in my comfort zone by asking, so no problem. So, my thoughts as you bring up that question are simply that there's nothing in the technology that's going to help us do much. It's going to be in the study design. So if you want to understand the differences between patient groups, you're going to have to put them all into a study together to compare them on the kinds of measures we get from fMRI, right? So if you wanted to compare celiac disease to multiple sclerosis for some reason, to figure out, you know, if you have an idea about different mechanisms, you just have to put them in a study together. That would be my best guess. And ultimately, you know, to try to get to some other questions I've seen that might be relevant, you know, we're only in fMRI, we're imaging blood oxygen to tell us what parts of the brain are activated, meaning doing something, right? And if that gets degraded in brain fog, we want to maybe we can see that kind of playing out in real time in a real place in your brain. We can make it quite real. But all we can really do to relate that information to the molecules of interest, the cytokines, right, or the microbiome, whatever it might be, is correlative at this point. Because the study design for the brain fog disease will be exposure followed by brain fog followed by these events, we kind of will have some basis for causative explanatory outcomes, but ultimately all of these things will just be correlative. Does the level of cytokine storm correlate with the level of disconnectivity we see among brain regions? That's the kind of outcome we're going to get. And maybe we'll be able to say, we'll pick out some of the cytokines that have the strongest relationships. So we'll be able to kind of hone in on which of those cytokines maybe have the strongest influence on these processes. So that's how molecular we're going to be able to get. It's ultimately just kind of correlative.
So when, you know, one of the questions was about the cytokine response and with the different patients with celiac disease and so on. And we do know that the load of gluten does make a difference, but we also know that all patients don't have the same symptoms. So would you anticipate the same sort of response if someone doesn't have brain fog? Let's say it's a celiac patient with abdominal pain.
So in this study, we're only going to bring in people who do have brain fog, but that would be an interesting group to bring in the future, you know, if we could get the studies to become bigger and have that as a comparison group, right? And getting a large enough study going will allow us to take into account those individual differences in what are their exact kind of symptoms, and does that help you predict the kind of brain fog outcomes that they have or their specific cytokine kind of responses. So the bigger the studies are, the more you can parse out all that heterogeneity. So absolutely, it's possible.
And I guess that's one of the things that we would want to learn to really be able to, first of all, diagnose the correct subpopulation that would help, and then thinking about medications for the future. You know, there are medications. I know right now the gluten-free diet is it, but if we could pick out which cytokines cause a particular sort of defect, if you may say, with the functional MRIs, can we then block that cytokine and not necessarily have to go even more hyper about our gluten-free diet? Would be I would imagine that would be the best outcome. Do you see that happening? I'm putting you out of your comfort zone.
You're exactly right. I was like, maybe so. You guys maybe have to tell me, you know, when it gets to tinkering around with neuroinflammation in particular. I think the field is really stuck with a lot of ideas how we could actually pull it off. But if we really do continue to hone in on those molecular mechanisms, I'm sure the innovation will get there.
So I think one of the questions was about the cytokines, and yes, the cytokines are different and there are some people that don't get that don't mount that response, and that was something that was seen in some of the studies. So time will tell, and this is one of the main reasons to start with this small pilot. To learn more. I mean, we kind of know about, I'll use the word brain fog and get yelled at by Dr. Keedy since that's not brain fog, but we know that there is this brain fog. We know that we need to learn more, and then perhaps this is one place where we could have medications that would help us in the future, since a lot of patients with celiac disease do follow a gluten-free diet, and it's often impossible at times to stay that gluten-free to avoid some of these side effects that happen. So looking at it from a technology, diagnostic, and perhaps treatment down the line is where this study would bring us. And I know, Rachel, there were more questions.
Well, I'm going to do one final follow-up to the study itself, and then we'll move on to another topic. So I'll start with you, Dr. Keaty. I just want to, I think you touched upon this, but I just want to address it directly. Will the brain fog study identify areas of the brain that change, or will it identify any underlying mechanisms causing the change and identify specifically maybe a component? Whether it's through the gluten exposure or something with the brain fog. So I just want to address that kind of specifically, what could potentially happen with this study.
So we definitely could identify specific locations in the brain that are affected by these acute gluten exposure associated events of brain fog. And let's acknowledge that's one version of brain fog. I think there's other versions of brain fog that people complain of with autoimmune disorders, but these acute gluten exposure related ones, yes, we might be able to localize where it's more common among the celiac disease patients. But again, getting to the molecular level of explanation, that's going to all just come down to correlation with the serum and the stool sample measurements that we get.
Thank you. Exciting. We're definitely looking forward to some of those results. And moving on with Dr. Jericho, questions about, as a gastroenterologist, we do biopsies. There was a question of why are we doing esophageal biopsies? I guess the question could also be, why are we doing the antral biopsies? And then there was another question of, do you really need to do a biopsy with celiac disease? And that could be a whole topic of itself. So I know we have a lot of other questions, so maybe we could focus on esophagus and a quick answer about the biopsy or no biopsy.
Yeah, so, I think, again, similar to Dr. Verma, I am a pediatric gastroenterologist, and I think in the world of pediatric gastroenterology, we do things a tiny bit different than our adult gastroenterologists. It's not unusual in kids that sometimes grossly things may be a little more subtle, and so many of us as pediatric gastroenterologists will get a couple of biopsies from the different aspects of the GI tract just to ensure what we're seeing under the microscope is consistent with what we're seeing grossly. I think this especially holds true for celiac disease, especially people of low positive serologies and they have minimal symptoms. Oftentimes we will go into the small bowel and grossly, actually, everything looks fairly normal. And if we were to not biopsy, I think we would miss very important information, because when we get those biopsies and we look under the microscope, even though things may grossly appear normal, it's not unusual that we do see some aspect of villus atrophy and those increase in the intraepithelial lymphocytes. So to answer the questions about the esophageal biopsies, again, we in pediatrics often will just grab a couple biopsies from the esophagus, the stomach, the small bowel, just to ensure there is a specific lymphocytic predominant gastritis that we do see with celiac disease in what's called the antrum of the stomach. So oftentimes that just leads more weight to the diagnosis should the findings in the duodenum be a little more subtle. So that's often why we get that gastric biopsy. But again, the esophageal, it's not specific to celiac, though we do often see things like eosinophilic esophagitis in these patients. Just because they have celiac disease doesn't mean they only have celiac. So, we do keep an eye out for those disease entities. And then coming back quickly to Dr. Verma's question about to biopsy or to not biopsy, as part of the screening, we typically will start with the blood testing. And there are guidelines that suggest if you have an elevation of your tissue transglutaminase greater than 10 times the upper limit of normal, the likelihood that you are going to have celiac is very, very high, especially if you have a positive, what's called an endomysial antibody on top of it. Again, having that TTG greater than 10 times the upper limit of the normal with that endomysial antibody, with or without symptoms, again, the odds you do not have celiac would be very low. And so the question's always, do you really need to biopsy these patients? There's a lot of dispute out there about that answer. Just from a personal perspective, I always lean towards the biopsy. One of the big issues and things that Dr. Guandolini many years ago had actually looked at with one of our fellows is, in those patients, if you were to forego on the scope, would you miss other things? And they actually found that a fairly decent percentage of those patients wound up having second disease entities, again, such as that eosinophilic esophagitis, H. pylori gastritis, just gastritis in general, or other disease entities that would have been missed if you hadn't done the scope. So it can provide a lot of additional valuable information. I think additionally, in the long run, a lot of people can come back later in life to questioning diagnoses. And I think having that biopsy confirmation really helps to add a lot of weight to that diagnosis, that it is accurate, that we have multiple different evaluation techniques that are all supporting a true diagnosis. So I do think adding that biopsy confirmation does add a lot of weight in the long run for the mental state of patients, and knowing that, yes, we got it right. There's, very little question that this is not a correct diagnosis. So I personally will always lean towards getting the biopsy if the family is on board. But yes, there are guidelines to suggest if you meet very specific lab parameters, you could potentially do without the biopsy. And I'll turn
So
over.
I'm going to jump in there quickly. This is a whole topic of another discussion, but these are ESPGHAN guidelines. These are European guidelines, and there's a whole story behind that. There's also children who can have an elevated TTG and not have celiac disease. So there is something called, we used to call it latent, but it's a different name now, potential celiac. So entirely different topic of discussion, and maybe that's our next CME, something to talk about at another time. But Rachel, I know you had another 1 or 2 questions, and we are getting a 2-minute warning right now.
I think we have time for one more. And I think, Lori, you can start with this. It actually brings me back to one of your case studies. But for patients who have been on a gluten-free diet for a period of time and are strict, do you see with some patients that you are seeing that there can be a presentation of some of these neurological symptoms, even if on a strict gluten-free diet after many years observing the diet?
I've seen some patients with some slight symptoms if they're on the strict gluten-free diet. Again, it could have been someone that was diagnosed later in life. We are diagnosing people in their 80s. So that could be part of the puzzle, I think, but again, most patients that are on a strict gluten-free diet, they may notice brain fog at times and things like that, but they're not having as severe symptoms.
And Dr. Verma and Dr. Jericho, if you have anything to add to that with patients that you see.
One of the things when we say strict gluten-free diet, we saw Lori's slides in terms of how can you really be that strict. So the problem is you often get some gluten that comes into your diet. And again, my favorite phrase is you've got to live in this world that's got a lot of gluten. So there's going to be some gluten cross contact that happens. Sometimes there's going to be, and that's, again, totally normal, I would say. This is going to happen, and none of us need to freak out about it because it will happen. So what is a totally gluten-free diet? So maybe perhaps those people who end up with some of these neurological symptoms down the line are not even aware because maybe they don't have symptoms, or they're really being as careful as they can. And perhaps the reason that they're having those symptoms is because there is some gluten that goes in, or it's an entirely different disease process. So once again, it goes to, if you're having symptoms that don't go along with your normal symptoms, get your team together, have a discussion with your clinical team, have a discussion with your psychologist, have a discussion with the dietitians. So important to look at other things as well besides celiac disease. But if you're, majority of people, once you're on a gluten-free diet and you're as adherent as possible, the risk of other autoimmune diseases do go down.
That's fantastic. So I want to thank Dr. Jericho, Dr. Keaty, Lori. This was fantastic, so informative. For all of these questions, they will be posted into our next session. We're going to take a few minute break. And for all of my attendees, please remember to join that second link on the main page. And once again, our presentations will be posted on this website next week, as well as videos. I want to thank this morning's session. It was truly informative. Thank you, Dr. Verma, as always, for being a wonderful moderator and adding so much content to this morning. I'm going to let everyone, we're going to sign off of this session, and we will see you on the next one at 10:55. We will have a hard start. Thank you so much.
Thank you.